So what's important to realize when talking about electroconvulsive therapy is that we're dealing with very severe types of major depressive disorder. And I assume that most of you are somewhat familiar with it, but major depressive disorder is characterized by depressed mood and anhedonia, which is an inability to experience pleasure, with accompanying symptoms such as sleep disturbance, executive dysfunction, and suicidal thoughts. Now, typical treatment for major depressive disorder can range from lifestyle changes to social support from family and friends to different types of psychotherapy like cognitive behavioral therapy or different types of pharmacotherapy such as SSRIs or tricyclic antidepressants. What most people don't know is that 1 out of every 3 patients will actually fail to respond to several types of conventional treatments and become what we call treatment resistant or treatment refractory. And so this is a very large group of patients with a severe disorder. And it's at that point, when other treatments have failed, that electroconvulsive therapy actually becomes a viable treatment option. So when I talk to people about that I work on electroconvulsive therapy, I often get surprised looks or questions like, is that even still being done, or is that even still allowed? And that's because most people, when they think about electroconvulsive therapy, they have this image. So I hope that the people here might recognize this image. So it's a famous scene from 1975, One Flew Over the Cuckoo's Nest, in which Jack Nicholson gets himself admitted to a psychiatric ward to escape a prison sentence. And in this psychiatric ward, electroconvulsive therapy is not used as a way to treat any sort of disorder, but actually as a means to control the patients or punish behavior that they think is unwanted. And this was actually in a period where the anti-psychiatry movement was gaining traction, becoming very big. So in these years, the 70s and 80s, actually ECT was considered an unethical treatment at one point. And it's only been in the past decade or two that we see a sort of research or a rediscovery of the huge potential that ECT has for treatment of major depression. So what actually is electroconvulsive therapy today? So like the name already implies, what electroconvulsive does is it uses an electrical stimulus to generate convulsive state, or in this case, a generalized seizure. And it does this by using a transform to apply electricity to the temporal window, either unilaterally or bilaterally. And as opposed to what the movies teach us, it's actually done in a very controlled setting with an anesthesiologist, under general anesthesia, under muscle relaxants. And the whole procedure takes about 2 to 3 minutes, roughly. You do this 2 to 3 times a week. And then over the course of several weeks, you see some very amazing clinical effects. So even in that patient group that is treatment resistant, so they fail to respond to several different types of treatments, including several types of medication, you see response rates of 50 up to 70% that respond positively to a treatment with ECT. So like Indira already mentioned, it's by far the most potent treatment we have for major depression today. Not only that, it's also the fastest acting treatment that we use today. So you get a response typically within the first 2 to 3 weeks, where another treatment might take 4 to 6 weeks to even start working, which means it's also ideally placed in those situations where you really don't have the luxury of time to wait for a response, especially, for instance, if there's a very high risk of suicide. So naturally, if we claim that this is the most potent biological treatment, understanding why it's so effective and how it works is one of the questions that has been on researchers' mind for quite some time. So early research in the early 2000s using PET imaging already found that there's a whole wide effects of ECT. So on the left you see early research during the seizure, where they see that there's a huge increase in cerebral blood flow in medial and temporal areas and frontal areas, which was actually followed by a state of hyperperfusion after the seizure. And on the right, you see that it's an image of glucose metabolism that actually showed a sharp decrease in whole areas of the brain, where they found a decrease in glucose metabolism after ECT. But I don't need to tell you that imaging has come a long way in the past 20 years. So what we aim to do, and this is going to be the second part of the talk, is we're going to present to you the review of all the available studies to identify consistent reports across MRI modalities. So what we did is we searched the literature for studies that involved patients receiving ECT either for a major depressive disorder or bipolar depression that used MRI to investigate changes in a longitudinal setting and had at least a decent number of subjects. And we looked at these papers to identify both the consistent findings between studies, and where possible also do a quantitative assessment of the results. So in total, we identified 37 studies that were published between 2000 and the end of 2017, which was the date for the abstract submission. On average, these studies had about 20 to 30 patients, but ranging from 10 all the way up to 88. Most of these studies used some form of structural imaging, 10 used functional imaging, and surprisingly 9 also used magnetic resonance spectroscopy, which relatively is a lot. And if you look at the patient characteristics of these studies, most used to include only unipolar depression, but also a significant part also included patients who were suffering from bipolar depression, ranging from 10 to 40% of the total sample. And most studies also allowed patients to continue medication during ECT treatment, which is also something that you would typically do, especially, for instance, people that also use antipsychotics. And considering the types of ECT, four studies used only unilateral ECT, about 10 studies used only bilateral ECT, but most of the studies use both, which is also something that you would do in clinic, where you start unilaterally, and then after no response within the first few sessions, you actually switch to a bilateral treatment, because that's slightly more effective, but also has a higher risk of cognitive side effects. So what I'm not going to do is going to talk to you about 37 individual studies, because then we'd be here all morning. Instead, what I'm going to do is I'm going to present, go through the different modalities and present the consistent results across studies. So to start you off, we're going to start on the structural studies. And there were 8 studies that used voxel-based morphometry on the whole brain to see if there were any increases or decreases in gray matter. And actually 7 out of 8 studies find a clear increase in volume in the medial temporal lobe. And all of these 7 studies included both the hippocampus and the amygdala within this cluster. And for some it was limited to that, but in some studies it even extended all the way into the temporal pole and the anterior insula. The anterior cingulate cortex was also reported in 4 studies, mostly pregenual and subgenual anterior cingulate. The insula, like I mentioned before, was also found in 3 studies. 4 studies also found an increase in volume in the lateral temporal cortex, and 3 studies found an increase in the striatum, most notably the dorsal striatum. Moving on, there are 3 studies who also had a whole brain approach and wanted to measure cortical thickness changes. And interestingly, all 3 of these find an increase in cortical thickness in the temporal pole. And for 2 of these studies, they also found that this increase extends into the insula, while the other study actually found that it extends into the lateral side of the temporal cortex. But they also found an increase in the cortical thickness of the anterior cingulate cortex, which interestingly also related to a clinical response. Now, the largest number of studies actually used a very focused region of interest approach, mainly to check for the volumetric changes in subcortical structures. Now, similar to the VBM studies, all 7 of the studies that looked at the volume changes in the hippocampus actually also found volumetric increase in the hippocampus. Similarly, all of the studies that looked at the amygdala found an increase in volume in the amygdala. And one or two studies that looked at regions outside of these report an increase in volume in orbitofrontal cortex and again in the dorsal striatum. And as the last of the structural studies, there were 4 studies that used different kinds of methods to look at white matter. 2 of these were whole brain approaches using TBSS. One used a graph theory approach, and one used specifically to look specifically at structural connectivity from the hippocampus. So there was one study that didn't find any changes in white matter, but all other 3 found evidence of changes into the frontolimbic structural connectivity using the different types of methods. So if we look at this from a sort of an overview, what we actually see is that even using sort of whole brain approaches, there's a clear focus on several areas in the medial temporal lobe, the temporal pole, and the medial prefrontal cortex. So extracting the peak voxels from the VBM studies, we also used ginger ale to perform an anatomic likelihood estimation. And again, we find the clear evidence that there's an increase in the bilateral hippocampus in volume, but also interestingly, we find that there's a hotspot within the subgenual anterior cingulate cortex. So moving on to the functional studies. So these were a little bit less, and also there's more variation in the type of method used. So the 3 studies that looked mainly at large-scale networks using ICA, they tend to focus on those networks that are also relevant in major depressive disorder. So they looked at the central executive network, the salience network, and the default mode network, which, as we also found from a review on resting state connectivity in depression, were actually also the 3 networks that were heavily implied in depression. So one study that found, so basically most of the studies found increases in connectivity between different hubs of these networks. So one study found an increase from the posterior default mode to both the dorsomedial and dorsolateral prefrontal cortex, while another study actually found a similar thing but in the opposite direction, an increase from medial prefrontal cortex, the anterior default mode network, to the PCC, which is one of the primary hubs of the posterior default mode network. This study also found an increase in connectivity between the basal ganglia and the dorsal anterior cingulate cortex, which is part of the salience network. And in reverse, they also found an increase in connectivity from the salience network, again, to the basal ganglia. This study also found a decrease in connectivity between posterior default mode and hippocampus. And finally, some of the work that we did ourselves, focusing on the default mode network, we actually find that within the posterior default mode network itself, several of these cores show increased connectivity to one another after ECT. So the other type of functional connectivity measures used is use a seed-based correlation analysis, and instead of these regions, they chose to focus more on the subgenual and subcortical structures. And what they find is an increase in connectivity between subgenual anterior cingulate cortex and the hippocampus, or from the amygdala back to the subgenual. And depending on where the exact seed voxel was placed, they found either an increase or a decrease of subgenual cingulate to the temporal pole. Finally, there were 2 studies using the amplitude of low frequency fluctuation studies, and these actually find exactly the opposite results. So that's very conflicting. So if you look overall to the functional studies performed in electroconvulsive therapy, what you see is that there appears to be a focus, at least from the network perspective. There is an important an important point to be made that the posterior default mode network is one of the key regions that's affected functionally. And what's also interesting, and which doesn't really show from this figure, is that most of the functional studies actually also include healthy control subjects, and that they tend to find that after ECT, the brain is more like the healthy control than at baseline. So basically, ECT somehow restores the dysfunctional patterns that are present in depression at baseline. So finally, I'm going to present to you the results from the magnetic resonance spectroscopy studies. Now, I'm not sure if possibly most of you are aware, is that MRS is a technique that's very locally specific. So you need to really define a very specific region of interest, and then you only get to measure at that very specific place. So the different kinds of metabolites under investigation, they all relate somehow to a neuronal, well, obviously to neurons. And they focus specifically also on similar regions that are found in the region of interest analysis using structural MRI. So the hippocampus, amygdala, the ACC, and the DLPFC. And I'm going to go over this quite quickly because there are such varying date changes. So interestingly, and probably not what you'd expect, is that overall you see a decrease in NAA, both in the subcortical structures as well as in the medial and lateral cortical regions. There seems to be an increase in choline and myoinositol in the ACC or the hippocampus. The measures on glutamate or GLX are actually, well, they're very inconsistent across different regions. And those studies that looked at creatinine find a decrease in dorsal ACC and an increase in the hippocampus. So these studies are very difficult to compare because not all of them report on all of these metabolites. So it's very difficult to actually see any consistency between these. So looking at all these different types of modalities together, what do we find? So we can see that very consistently reported there are changes in the medial temporal lobe, and one of the other regions that are found across modalities is the anterior cingulate cortex. And other regions of interest that don't show up in all these modalities but are definitely of interest are the temporal pole, the insula, and the dorsal striatum. So talking about these results in a little bit more detail, if we talk about the medial temporal lobe, it's actually very in line with the volume increase that we find in major depressive disorder. So a decrease in hippocampal volume is actually one of the hallmark features of depression. And very interestingly, is also most prominent in those types of depression that are either recurrent or treatment resistant or are chronic, which is also specifically, typically the type of patients that are more likely to receive ECT. What is interesting, though, is that even though this is such a significant finding, very few studies actually report on any relation to clinical outcome, which is probably partly explained by small sample sizes. But some studies that use follow-up studies also find that this increase might be transient. So there might be an increase after ECT that's not there 6 to 12 months after treatment. And also that that's also similar to what we find in depression, where the amount of decrease in hippocampal volume is actually not all that well related to the clinical phenotype. So for the anterior cingulate cortex, as you might know, it's a very heterogeneous area. Right? So as we find as well, there seems to be very locally specific effects to be either an increase or a decrease in functional connectivity. But there's definitely an emphasis on a subgenual anterior cingulate, again, similar as we find in depression. And it also fits with a known volume decrease in the subgenual anterior cingulate in MDD. What's interesting is that the anterior cingulate is also the target site for deep brain stimulation, so it has a very important part to play in the whole treatment of depression. And again, the other areas of interest are the temporal incidence striatum. I'm not going to go into too much detail of this. So there are quite some methodological considerations. So typically these ECT studies have very small sample sizes. So on average about 20, but even as few as 10. There's a very limited relation of any of the findings to any of the clinical work that we've done. Again, probably related to the small sample sizes. But also important to note, especially in the functional NMRS studies, that they use very different approaches to analysis. And as I showed before, they use very different clinical characteristics, so either on or off medication, different types of ECT. But what I didn't show here is that there's also different definitions of when a patient is actually treatment resistant, which can range from not responding to 2 different types of antidepressants to going through a whole schedule with lithium addition and MAO inhibitors and up to 6 different kinds of antidepressants. So what do we need? Well, we need bigger samples, as do all. But gathering data on ECT is quite an undertaking, so it's important to also establish some collaborative efforts, which my colleagues will also talk about today. Using new methods of analysis to use the data that we have in a much better fashion and to help us better understand what's actually going on. And also something that hasn't really been done so far is integrating different modalities of imaging to better understand the relationship between structure and function, which is also one of the also one of the main topics of many of the talks I've seen at OHBM already. So with that, I'd like to conclude my talk and thank my colleagues